Hi, welcome to episode 3 of the Healthcare Triage Podcast. We're so pleased that you've continued to join us on this new and exciting venture. We still need your questions. Go to healthcaretriage.info and get those in, because that's how we make this wonderful content. This week we have a guest. It's Dr. Tim Broach, a good friend of mine who's also a palliative care physician. Because we get so many questions from you about palliative care, we thought we'd bring an expert in to talk to us and answer them for you. But first, some news. The biggest thing, if you're listening on Friday, is that CHIP might not still have been reauthorized. We did Healthcare Triage News in this last week, at which point I was in a panic. Now all of you should be as well. The funding for CHIP ran out on September 30th. They still have not re-upped it, and while everyone has said to stay calm because they're going to do it any day now, if it doesn't happen on Friday, the government's shutting down. Well, that's because they have to do it as part of the reauthorization of the entire government. And if they haven't done it by now, there's a really big chance that the government's going to be shut down by the end of the day. That will, of course, have repercussions not just for CHIP and for healthcare, but for everything in the country as well. So it's a big deal. You should pay attention. Also in the news, CVS is getting close to merging with Aetna. That's a pretty big deal. In fact, we might do Healthcare Triage News on it this week if we haven't already gotten around to it. If you haven't, you can read Austin Fract about it in the Upshot. He had a pretty good piece on Monday. Also, the big news of last week was the Senate finally passed their version of this tax bill, and in it, there were some pretty big changes to healthcare. The biggest being that they repealed the individual mandate. You've watched many episodes, I'm sure, where we've discussed the individual mandate and what it means. Its biggest deal is that it incentivizes healthy people to buy into the exchanges, which is necessary to keep a balanced risk pool so we don't wind up going into a death spiral. Here's the thing. We don't really know what's going to happen if they repeal the individual mandate. It's possible that a lot of concerns, even those that I've voiced, have been a bit overblown and that things won't be as bad as they seem. Or it could be that things get much, much worse than we feared and all the healthy people stop buying insurance, even getting Medicaid, because there's really no need to get it unless you're sick, in which case the price of everything seems to go up. The full ramifications really aren't known at this time. It's something to watch, though, especially as this bill goes to conference. It's not clear whether the House will keep in the individual mandate repeal or whether the Senate will keep it in as far as they go anyway. A lot of this rides on whether they get in some of the language we've talked about with the Murray-Alexander compromise in trying to get the cost-sharing reduction payments back in, because Susan Collins has said unless that compromise gets a vote and gets passed and a lot of other fixes occur, her support for this bill isn't fixed, meaning that she could turn around and not vote for this in the final version. Why is that important? Because you've already got Corker that said no, and it's very possible that if Doug Jones beats Roy Moore in the Senate race in Alabama, that there wouldn't be enough votes in order to get this thing passed, even if they made all the fixes they're talking about. So there's a lot still going on. It's all very fluid. I guess the bottom line is you should still remain panicked about everything, but we'll see how things go. Speaking of death spirals, let's talk about palliative care. Our guest this week is Dr. Tim Broach, who, besides being a very good friend of mine and a frequent dungeon master for our gaming group, is also a palliative care doctor, but it's not what he always did. So I'm going to let Tim introduce himself, talk about his career, talk about what he's done, and then we'll get to some questions.
Thanks, Aaron. It's great to join you guys today. I was not always in palliative care and hospice, which are the two roles that I currently hold. I am trained as an internist from Indiana University and was in that role within the hospitals as a hospitalist for about a decade. And so I got to see on the front lines of general primary care inpatient medicine the consequences of serious illness, the symptoms it causes, the floundering that both healthcare professionals and families sometimes struggle with when they go through these illnesses. And that led me over the course of a decade to wanting to focus on palliative care and end-of-life care.
So one of the things that I hear often about palliative care, and again, I think it's not true, but I feel the need to talk about it just so that it's out there, is that palliative care is giving up. It's like, okay, you're going to die. We don't care about you anymore. Let's just let you go. So it's clearly not, but could you give us a better definition of what exactly palliative care is?
I think the first thing to acknowledge in healthcare, period, is that we have diseases that we cannot cure. And that's unfortunate and sad, but that is the reality. We have heart failure, lung diseases related to smoking, certainly advanced cancers, on and on and on with different diseases we just cannot cure. In those cases, though, modern medicine has made many, many advances, and we can now live with those diseases for any number of months, years, decades. But what do we go through as a consequence of living with those diseases? We have symptoms that we have to manage through those diseases. We have large life decisions we have to make in the context of those diseases. We have to think about who would speak for us if those diseases advance to the point where we can't. And we have to think that in the last months of our life, whenever that occurs from these significant serious diseases, how aggressive, what care do we want? And palliative care addresses all of that. So it's certainly not end-of-life care. The death spiral joke cuts to the core.
Sorry about that.
And I do hospice, which is end-of-life care. But palliative care begins and should begin much earlier than that for anybody who has a serious chronic illness that causes significant symptoms and distress.
It's fascinating you bring that up, because this is one of those things that's always baffled me, because as I've talked about on the show many times before, I have ulcerative colitis. There is no cure. So I have spent much of my adult life managing a disease which is never going to go away. And so my goal isn't like get rid of it. It's, can you find me the best way to live for as long as I can in comfort while I have this disease? And I take on risks. I take on problems, including some very potential significant side effects by taking the medication, but it's fine. It's the best way for me to get the highest quality of life for a long period of time. I feel like palliative care is like that, but for illnesses which are perhaps more severe, where death is a much more close consequence, perhaps.
Correct.
Do you think that, is that a valid way of looking at it?
Absolutely. And I would actually even suggest that even somebody with relatively well-controlled ulcerative colitis might benefit from at least one visit, theoretically, with a palliative care physician early in their life to begin to think about sort of big picture things.
That's really interesting. So what happens in a palliative care visit? What exactly occurs?
So the first thing that we talk about in palliative care is goals. And we say that because what we ultimately want to do in medicine of any kind, whether it's palliative care or otherwise, we want to make sure that the goals of the patient, whether it's curative or if it can't be cured, I want to extend my life, I want my symptoms to be controlled, line up with the therapies that the physicians are offering. And there's a big disconnect there often. And it's not because of intent, usually. It's just that we speak two different languages. And palliative care, first and foremost, is talking about goal setting. So we spend a lot of time in a palliative care visit talking about, what does the patient do? What do they value? What are the things that give them meaning in their life? What are the things that they cannot do without with regards to their day-to-day existence? And then we talk about, in the setting of their disease, what if X happens with this disease? And we try to give them some sense of the likelihood of some outcome happening with their disease.
I'm screaming in my head while you talk, because what you're describing is what all physician visits should be. And it's just another instance of what is wrong with medicine in this country, that we have to send someone to a specialist to get basically patient-centered care, which is what everybody says that they want all of the time. And it's just crazy. You're not describing, I'm going to manage your death. You're describing, I'm going to listen to you and care for you and try to get to the goals that you want. But that should be all healthcare.
Absolutely. And I would say that one of the thrusts of Indiana University School of Medicine palliative care is to focus on primary palliative care, which we define as, let's teach people in all specialties how to do palliative care and how to have difficult conversations and how to lay out goal setting and advanced care planning. So that's actually one of the key thrusts of palliative care nationally is there will never be enough palliative care specialists who are trained to have these hard, really difficult conversations and nuanced conversations. We really need to be able to teach and hone these skills of the primary caregivers, whether it's a cardiologist or an oncologist or a neurologist or just a family practitioner or an internist, to have these palliative care conversations.
Still, though, I would imagine most of the patients you see have very serious illnesses that
Correct.
are going to lead to death.
Correct.
So, I'm thrilled that they are finally at the end of their lives getting the patient-centered care they should have been getting forever, but at least it seems like they're getting it now. Still, though, when those patients come in, I imagine, are most of the goals they're talking about what they want to do for the next few months, for the next few years? Are they talking about their deaths? What does the conversation usually go?
In a perfect world, it would be, what do they want to do for these next few years? Mm-hmm. So for a severe heart failure patient who has probably still many years of life, you still would want to talk about that. For a cancer patient, it can often be, what do you want to do for these next few months? When you raise the question of death, and that, of course, is the unspoken word that hovers over all of these palliative care discussions, it is something that we acknowledge a lot because in the United States, death is not something that we deal with well.
No.
Part of our training is to be able to say that word and not dodge it and not use a euphemism for it, but to do it compassionately and respectfully, and then to help patients begin to process how they think about it.
So one of our running themes on Healthcare Triage is that I completely agree with you. We are horrifically bad at talking about death. We all believe we're going to live forever. And every new scare study that comes out is trying to convince you to have no joy, no fun, change your behavior on the hopes that you will decrease your risk of death 40 years from now by like 0.0001%. And it makes no sense because there should be trade-offs.
Right.
But clearly, you're going to die. I mean, we've even had episodes where we make that as a joke, like, here's the bad news, you're going to die. Everybody's going to die. Do you feel like when your patients get to you, they have accepted that at a better rate than Americans in general, or are they still very much in denial?
A lot of them are still in denial. That being said, we also have some folks who have fully processed things, and a lot of our conversation is simply confirming their thought process. But unfortunately, I would say the majority of folks are still wrestling with it. Not inappropriately, by the way.
No.
It's a big deal.
Of course, yeah. I'm a totally big deal. But I would imagine that by the time they've said, I'm going to see a palliative care doc, they have at least processed it better than some, that death is in the future.
Right.
Because otherwise they probably wouldn't be coming to palliative care.
Correct.
But you're saying that even so, many of them still have some distance to go.
Sure.
How do you get them there?
I think you talk again about what are their goals, and it may be simply I just want to add more days to my life at whatever cost. That's fine. That's their goal. But if their goal is, I want to be able to hike for as long as I can, or I love spending time with my grandchildren and I want to do that for as long as I can, then you can pivot into talking about rough guesstimates on how long they will have, et cetera. And at that point, you're also starting to talk more about only end-of-life care and not just palliative care in general.
And I want to get to that end-of-life care, but I have actually some other things which are popping in my mind right now. So how often do you see a patient?
Well, you would see a patient sometimes if there's significant disease burden. We might see them monthly even for a palliative care visit. More often, you might see them every 3 months or every 6 months. The other thing that we are doing at Indiana University is that we are embedding our palliative care physicians within the specialty clinics. So we have our palliative care physicians are working within the heart failure clinics. They're working within the oncology clinics, within our hepatology, liver disease clinics, so that they can meet those patients where they are and make it more simple logistically for the patients who have to come into those visits.
And that was actually my next question. Like, do you have an office where people come, or do you go to their offices, or do you go to the homes, or where do you see patients?
Most of the time we see them in the hospital, because those are your crisis points. We see them in these specialty clinics. We do have a standalone palliative care clinic. And man, in my perfect world, I would love to be able to do a consistent home visits. We're not quite there yet for a variety of reasons, but community-based palliative care, which is the phrase that we use for that, is sort of the holy grail of what I personally would like to be able to see.
So what are the barriers? Like, what's preventing us from getting there?
Reimbursement.
Is it that the insurance companies won't pay if you do a home visit versus if you do it in the hospital?
No, you can get paid for the physician fees, but by definition, palliative care is not just a physician. It's always interdisciplinary. It always involves a social worker and a nurse and a chaplain. And it actually can bring other specialties in as well, or their clinical specialties, physical therapy, music therapy, art therapy. Bringing all of those to a patient in the home is expensive.
Oh, okay. Well, I guess that makes sense. I was going to get angry at insurance companies, but it would be, I can see it also being logistically difficult if you're trying to get all of those different clinicians or practitioners in some way to the same place. That would be difficult. Although you could imagine, I suppose, some kind of like roving unit.
Sure.
Where you did that, but no, I get it.
Well, the hospice model of care, which is in the home using all those specialties and is reimbursed differently by Medicare and other insurers, is that model.
Well, let's talk about that. So when you say hospice care, what exactly is that?
Right. So palliative care can start ideally many years before a patient faces the end of life. But in those last several months of life, new challenges arise, and the philosophy sort of turns on its heel a little bit. You are now recognizing that there's nothing more that can be done to prolong your life. So the poster child for that is chemotherapy for an oncology or cancer patient. that there's no more chemotherapy options for them. And some patients make that choice on their own. They say it hasn't been worth it. This is not meeting what I want to do. I'm not going to do any more chemotherapy. Or some patients, it only comes in the last few days or weeks of life. At that point, we transition to hospice. And this is a movement and a philosophy that arose in Britain, actually, in the mid 20th century, and then was transported or translated into the U.S. in the 60s, and then has spread. In 1983, hospice was recognized as a pilot benefit for Medicare, and was then continued and made into law. And it is actually, the last I heard, it's actually the most rapidly rising area, cost-wise or expense-wise, for Medicare within their budget. But the goal is that it overall decreases their costs, so they support it.
Right, exactly.
Philosophically, though, again, we're meeting the patients where they are, ideally in their homes in the U.S. And it is always, again, interdisciplinary because it is in the spectrum of palliative care. And we focus on symptom control. We focus on quality of life. Sometimes hospice is done in a hospital, particularly severe symptoms, pain, shortness of breath, really significant confusion, which can sometimes arise at end of life. And as a palliative care physician and a hospice physician, we try to treat all those. There are also hospice facilities where people go for end-of-life care, whether it's severe symptom control or simply because that's an environment that they would choose to go to. And those facilities provide all of the full spectrum of hospice care that you normally would have.
So one of the things that's always fascinated me, and I wish I had my head wrapped around it better, was that I've seen studies in the past, let's say, decade, that showed – because, I mean, the context of this is that I think people have a assumption in general that when people choose palliative care or hospice care, they have given up, they are ready to die, and that you're just trying to keep them comfortable and speed them along to death. But I've seen studies in the last, say, decade that show that often when people are at that inflection point, when they decide one way or the other, that often when the people that choose palliative care seem to live longer. Why? Like, this is what I don't get. Like, I'm willing to accept it as an answer, but I haven't seen many studies that will get at why we think they're living long. I mean, we hope they're living better because they're getting their goals met. Do you have any idea why you think they might live longer?
You know, it's the study you're referring to in particular was a lung cancer study where patients who were enrolled in primary care versus the control group that were not they had a longer, I think it was roughly a 2-month longer survival on average. You know, and there's certainly discussion within the palliative care world about why that is. I don't know that we have a definitive answer. I think our suspicion, though, is that the other aspect of palliative care, which we haven't talked as much about, is symptom control. And I think that that's important. If I'm nauseated all the time from my chemotherapy, and my oncologist, who is well-versed in trying to treat those side effects, but is trying to mostly treat cancer, isn't able to adequately address my nausea on a consistent basis, adding a palliative care clinician to the mix might be a way to help that. And if I get my nausea under control, I live a better, longer life. I'm more active. I'm more up and around. Same with pain, same with insomnia, same with depression, same with anxiety. All of these are symptoms that we address. And it's not that any other clinician can't address them, but we actually focus on them, one. And two, we talk a lot about other options, lifestyle options that can treat them. So, for example, pain. Opioid crisis is in full swing, right? And we use opioids all the time, particularly for cancer pain. But we have a lot of other tools in our toolbox to treat pain that are not opioids.
Right.
And so when we focus on pain, for example, we'll start to talk about the emotional aspects of pain, and we might use an antidepressant for their pain, particularly one that has pain effects. We might focus on lack of sleep as a root of some of their pain, and we might focus on how we can improve their quality of sleep. We might talk about how do you deal with your pain and it limits your functions. We say, well, let's get an occupational therapist or a physical therapist. And the overall effect, though, of treating these symptoms appropriately is that a patient can live longer and better, even when they face a severe disease, like, for example, in the study of lung cancer. I'm
struck again, and I have to comment out loud about how everything you're describing should be just part of medical care. I mean, not to say that your specialty isn't necessary, but when you're describing, well, we need to holistically treat symptoms and we need to be – of course we do. It's just so baffling to me still that we need almost a specialty to do this. But as you talked about it, it makes perfect sense. The oncologist is trying to cure the cancer, not manage the nausea. That's what oncologists do. And so we probably do – yeah. There's got to be a better way, or you just assume. So one of the other things Healthcare Triage listeners seem to love is any discussion of pot. So clearly in Indiana it's illegal, but in other states it is not. So how often is marijuana used these days? Is it more often than before with respect to hospice and palliative care? And is it something you see expanding?
Yeah, it is more common, and sometimes patients cop to it and sometimes they don't.
Right.
In Indiana, it's the cannabidiol oil, which has been, whether legally or illegal, it's being sold in our healthcare stores.
I know it because I hear about this all the time, and I even have friends who continue to talk about it. There's no evidence for that at all, right? I mean, even with respect to pot?
No, there's not. There's no hard evidence. There's a lot of anecdotal evidence, and it is, again, one more tool in the toolbox. And as you and I have talked about before, it's just a chemical.
Right.
It's no more or less good or bad than other chemicals.
I'm on board.
Right.
I just keep telling the people that ask me, I'm like, if you want to use pot, use pot. Like,
Correct.
I don't get
Correct.
the oil. The oil is it even it doesn't have THC in it even. Like, I don't understand.
It has a little bit, but not.
But not the
right,
same.
Right.
Okay.
But it's more available, right? They don't have to go shady to obtain.
I ask only because, and I ask about marijuana in general because it just seems like a lot of the symptom management you're describing are some of the few things that marijuana has been extensively studied.
Absolutely. And to be very frank, if it ever was legalized, I think it would be another tool that palliative care doctors would reach for.
Another favorite of Healthcare Triage, of course, are death panels, which arose from the discussions of advanced directives or trying to make plans. And we've done a couple episodes, but clearly you're going to know more about this than we do. So we'd love to hear your thoughts on advanced directives and planning and who does that.
Absolutely. So one of the other core tenets of palliative care is to focus on advanced care planning. And this takes several forms. We think of living wills, for example, as being advanced care planning. And so this is a document that you might fill out when you're well that gives some guidelines on what you want for care under certain situations. The problem is that's a legal document, but it's not a medical document. And it doesn't translate very well at the bedside. It gives your family and loved ones some guidance, but it's often not nuanced enough or specific enough to apply to a specific situation. What we strongly advocate is that rather than only a living will, that you use a living will as a conversation starter for your family or friends so that they have some understanding about what you value and don't value as far as quality of life. And then that you designate someone, again, family, friend, otherwise, as a medical power of attorney or a healthcare representative. And those are different things legally. The medical power of attorney has a little more solidity to it within the legal world. The healthcare representative is filled out at the bedside. But in both cases, you've chosen a spokesperson. And that allows a lot more nuanced approach to end-of-life care or serious illness care when big decisions have to be made.
I've seen a few things in the news recently, though, where I don't know if it's doctors are pushing back or the system is pushing back and saying that there are problems with advanced. Do you know what that is specifically?
Well, I think there are sometimes concerns that it was not done in good faith. Mm-hmm. That can be the case. It can sometimes be the case that the clinical team is uncertain if the patient can make their decision or not. And then there can also still be disputes within a family, despite all the evidence to the contrary. And actually, that's one of the other hard parts of being a clinician at the bedside sometimes is that you have a document in front of you that states what the patient wanted. You even maybe have a healthcare representative or a medical power of attorney who is trying to honor that, but you have other family members who have strong feelings to the opposite. One of our goals in palliative care is to have those hard discussions.
Yeah.
And we do that at the bedside, particularly on our inpatient consult teams. We try to help navigate those difficult discussions.
So now's the part of the show where we answer some of your questions, and I'm going to have Tim stick around because when I fail, he will pick it up and run the rest of the way. So first question comes from somebody with no name, and they're basically saying you hear all the time that you're advised to talk to your doctor or healthcare practitioner before beginning any kind of new diet or exercise regimen. Is that really necessary? Do I really need to do that? Oh, God. First of all, let me state, as always, I'm not giving you actual medical advice. I'm not your doctor. I don't know you. So legally, you can't hold me responsible for anything I'm about to say. Anyway, I don't tell my doctor before I'm engaging in any kind of new diet or exercise. Of course, I'm not engaging in any kind of exercise which is going to be harmful, and I have a pretty good sense of what I can do. I think if you have a serious illness, if you have a reason not to exercise that you know about, then you probably need to talk to your physician before you do anything strenuous just to make sure that it's safe. I don't know. Tim, you can jump in here too, but I don't ask my doctor.
No, I think it's always context. So if you have a special medical condition, you should probably talk with them about it. A diabetic, for example, who suddenly increases their exercise will have to also adjust their diabetic regimen. A patient with heart disease will need to talk with their cardiologist or their primary care doctor if they suddenly ramp up their exercise regimen. Likewise, a heart failure patient, if they go on a special diet that changes their sodium intake, or a patient with kidney disease that changes their sodium or potassium intakes, they would need to talk with their doctor.
See, that's why an internist is going to answer that better than me, a pediatrician, because there are patients who have to do that. I just never see them. Anonymous asks us, are there any home activities or things that you can do to slow the advances of Alzheimer's? And that's a great question. And this is one of those where I'm going to let Tim jump in and answer this as well, but I'll give you my answer first. I think most of them are pretty common sense stuff. Like, you want to remain cognitively active, but that doesn't mean that you need to sit at home and do crossword puzzles and stress your brain. It means that you want to engage in human contact and conversation. It means that you want to read. You want to do things which keep you active, including exercise, moderate exercise, including eating right, doing all the right things. But you want to not close up, live in a house by yourself, never speak to anyone, and give up. That a lot of those continued activities of daily life are going to make a difference in your long-term cognitive impact. But I will admit up front, I see 0 patients with Alzheimer's disease. Tim, on the other hand, probably does not. Tim, on the other hand, probably does.
Yeah, and I think to be upfront, I don't have these studies memorized in my head, but I think it's important to know that there have been a lot of studies that associate an activity with lower risk or higher risk of Alzheimer's. I don't have it in my head that there are specific studies that there's a randomized controlled trial that shows definitively that one activity will improve or worsen your risk of Alzheimer's. That being said, I think Aaron's point is well taken. Exercise, mentally and physically, a moderately safe diet, these are all things that I think we would support for anybody, not just Alzheimer's patients.
Next question, also from Anonymous. You guys really don't want to take any credit for your questions, but that's fine with us. What training in general do medical professionals get in obtaining informed consent, doing advanced directives, or acting as medical proxies? So I'm going to take part of this, and I'm going to let Tim take a part of it. So informed consent is a nuanced thing because there's multiple types. The type that first comes to my mind is with respect to research and getting informed consent for patients to be part of studies. And that is a very specific definition that most healthcare providers are not trained to do. You need to get special, usually research training or certification in order to get patients to enter study and make sure that they understand what they're doing. Of course, there's also informed consent for procedures and other things. And there, still, the training is not nearly as formal as it needs to be. Usually, you wind up getting a doctor who runs through a list of potential side effects and then gets you to sign a piece of paper. They're trying to do it as fast as possible and minimize the downsides and sort of maximize the upsides. And even when they do it fairly, it's not the best thing in the world. So training there is not as good as it should be. But with respect to advanced directives and even to further comment on that, I'm sure Tim has more to say.
Right. And I think with regards to informed consent, I do think it's a recognized weakness of medical professionals, the ability to obtain informed consent correctly. And I would say that at least at our institution, Indiana University Health, there is some effort to demonstrate to physicians and other clinicians the appropriate way to get informed consent, but it's certainly not codified or formal and intense as it maybe could be. I think with regards to advanced care planning, unfortunately, the most training we get is about code status. So do you want CPR? Do you want electrical defibrillation or pacing? Do you want to be intubated and put on a ventilator? All in the context of your heart and lungs stopping. And I would say we get modeling behavior from those who are training us. We get some didactic sessions or teaching sessions about how to have those conversations. And then we end up doing it a lot. However, I would still say that all of that training is probably inadequate. And it's one of the things that within palliative care, we actually focus on our training and how we have those conversations. And it is in the context of informed consent. How do you truly explain and put into a good context for a patient the pros and cons of any medical intervention.
Yeah, and it's one of the, again, it's so baffling because it's in so many ways you think like, well, we should train for the stuff we're going to do all the time. That's the stuff we should focus on and be trained to do. Everyone's going to die. Everyone's going to have this conversation. It would seem like something that we would say you must be trained to do this well because it's something you will have to do with every patient as opposed to a lot of the disease management, which of course is not going to happen very often. But once again, there's lots of room for improvement in the U.S. healthcare system. As a follow-up question, and I don't know if it's from the same person or someone else, one of you asks, what do we do if someone withdraws informed consent or basically cancels it in the middle of a procedure? That is a question that, at first blush baffles me because I'm just, of course, imagining you're under general anesthesia and can't do it. But of course, as Tim pointed out to me, maybe you could be under local anesthesia and stop. So I'm going to guess with no legal knowledge here that a physician would need to make a nuanced decision. If you're in the middle of something which cannot be stopped because that would be more dangerous than completing it, they may demand or say that they have to get to a point where they could safely stop. If they had not yet gotten to that point and could stop, I imagine they would have to.
And I think I agree, that's exactly one of the pieces. The other piece is capacity. You have to decide, does the patient have the capacity during the procedure to make that rational decision based on the pros and cons that they are weighing? Somebody under local anesthesia, probably, almost certainly they would have capacity. Someone who's under any sedative, conscious sedation, they probably aren't able to make a rational, nuanced decision about stopping a procedure or continuing a procedure. And I don't think that the medical professional would be able to safely say that they have capacity to make that decision.
Yeah, I'm trying to think like where this might have occurred or what. And in the context of my world, I could imagine they consent to getting the 3 shots that they're supposed to get in a visit. They get shot 1 and 2 and the pain is, they're like, no! And of course you just stop. What are you going to do? But I don't know. I'm sort of wondering how often this might actually happen.
What about during a colonoscopy?
Yeah, well, I'm out for my colon.
Right, and
I have
that's what I think.
colonoscopy next week. Woo! But I've planned the anesthesia is the only good part of it. So,
right, and I don't think even if someone in a colonoscopy said that groggily said that they wanted to stop, I don't think.
No, because I would imagine. I mean, I always am baffled because if you've never had a colonoscopy, one of the most fascinating parts is that they give you the anesthesia and they tell you to count back from 10, and you never make it to 0 because it's like 10, 9, 8, 7, 6. When are you going to start? We're done. And that's the game I play with myself. Is always like I'm going to make it to 0 this time, and I never do. So I don't know how you'd stop it in the middle because I'm out.
Yeah, there are some patients who report not being completely out during the procedure,
terrible.
And you can imagine in those situations, if they say no, the doctor would be faced with a tough decision.
Here's a question that I'm thrilled someone's asking. I feel like we've talked about it in previous episodes, but it bears repeating. Why do doctors often have trouble interpreting test results? So I can't stress this enough. You only should be ordering tests in certain situations where you absolutely know what you're going to do with the results. Too often I will see physicians order tests with the idea of like, well, let's just see what it says. That's not how the tests were designed. That's not how the tests were studied. You have to remember that every time a test is created, it's for a very specific population with a very specific reason where we know what the results are and the cut point, and we know that if it's above or a certain amount, that there's a certain percentage chance that something is therefore associated with the disease or not. But if we extrapolate that and bring it out to a larger population, we have no idea what the test means. So when doctors get CBCs or sets of electrolytes on well patients, we often have no idea what that would mean because we don't do big studies to see what are the white blood cell counts on normal patients. We do studies that say if you're very sick with a certain number of symptoms, what do white blood cell count means? And so the people, I think we did a whole episode where we talked about Mark Cuban because he was advocating getting tests like every month or so or week. I can't remember. But regardless, we don't know what to do with those lab results. And so that's often what's happening is that a doctor gets a bizarrely strange value on an otherwise healthy patient, and we have no idea what that means because we haven't done a study to see.
I think there are 2 other situations to consider. One is an imaging study. So you can get a CAT scan, you can get an ultrasound, you can get an MRI. And I think what is not clearly understood is that those don't tell you exactly what's happening. They tell you is there increased blood flow to an area or not? In the case of a CT scan with contrast, for example, we interpret that as inflammation or infection, but we can't actually say that that is a gallbladder infection. An ultrasound can tell you there's fluid somewhere, for example, but it can't necessarily tell you the nature of that fluid. An MRI can say there is a lesion in the brain, for example, but it doesn't say exactly what that lesion is. We do studies with all of these imaging tests that say when something looks like this, it's usually that. But that's not 100%. Right. The other context, I think, is that sometimes a single data point of a test is not in itself helpful. It could be that individual's number and it has no significance. And sometimes it's better to trend over time, and that tells you information. I still don't think monthly, completely blind studies like Mr. Cuban has suggested are very helpful. But if you have a symptom that you want addressed and the physician does a lab or an imaging study that gives them some information, but they can't at that time understand exactly what it means, then I think a repeat test, whether it be a lab or an imaging study in the future, and then you follow a progression, that trend has more value.
Yeah, and as you were talking about the imaging studies, what really came to my mind is, of course, each of those things that you find requires the doctor to order another test, and you wind up on these diagnostic odysseys where you're getting test after test after test. And so often at the end of those, there's nothing there, but you've spent gazillions of dollars and endured tons of pain, and for no good reason at all.
There's entire medical literature about the incidentaloma, right? So the lesion that you incidentally find on an imaging study, and what do you do then? And so there's an entire body of studies about what do you do with that? What is the likelihood that that's bad or not? What studies do you do? What follow-up do you do?
So I'll give a personal example here that maybe Stan will cut, but regardless, you guys seem to love when I talk about my own personal medical history. But in medical school, I had really bad belly pain, and I was bad enough I went to the hospital, and they wound up admitting me. And then they put me on what we called the C service overnight. I somehow wound up on like the big ward service. No one came to see me. By the next morning, I was completely resolved, and I was like, just send me home. But they started to panic that they had not even like acknowledged a medical student's pain. So they sent me to follow up. And they're like, well, let's do all of these tests. And so they did all of this stuff. And so I wound up getting, by the end of it, for belly pain that had completely resolved, an echo because they thought that they heard a murmur. I had a CT scan of my abdomen. Then they thought, well, maybe we saw something in the kidneys. So they wound up doing an IV8, what is it called now? Whatever it was, they put dye in and they watched it through my kidneys. Then they found some blood in my urine and they panicked. So they did cystoscopy. So cystoscopy, ouch, for those of you at home, is when they basically they took a lidocaine gel and squeezed it up my penis to numb it, and then put a tube up my penis to look into my bladder. I had just started dating Amy for like a week when this occurred, and she
hi, honey,
drove me to the she laughs about this still, but I had all of these tests. Nothing was ever found, but it was unbelievable. And still because of it and the blood they found in my urine, they demand to repeat the cystoscopy every 10 years. So I just had that again just a couple years ago. So yeah, I'm not a big fan of like doing tests to look for stuff when nothing's there, because you wind up getting gel and a tube shoved up your penis. There you go. So thank you so much for tuning in. Tim, I can't thank you enough. This has been phenomenal, and I'm struck by how much even answering the questions was improved by your being here. So again, go to healthcaretriage.info. Could not be easier to give us your questions, and we will often do them here on the show. And give us your name. We'd like to credit you for the question. While we've got you, we like to talk about things like, putting tubes up your penis that not everyone wants to often put ad space on, but we don't care. That's the kind of stuff we talk about, but we appreciate any support that you personally can give the show. And one of the great ways to do that is through patreon.com, a subscription service which allows you, the listener, to help us make the show bigger and better. You can go to patreon.com/healthcaretriage if you'd like to support us, even if it's like $1. We'll take anything. While we've got you also, it's holiday season. Get your Healthcare Triage merch at hctmerch.com. That's through DFTBA, but that's the easy place for you to find all our stuff, hctmerch.com. And of course, my book, The Bad Food Bible, available in stores now. I'd really appreciate your picking up a copy. We'll be back in 2 weeks. Keep on listening.